Good afternoon, everyone. Welcome, and thank you so much for joining today's open session of the All of Us Research Program Advisory Panel. I'm Rachel Peterson, Chief of Staff. First, I have a couple housekeeping notes to share. As attendees, you'll note that your video and audio are turned off, but you may submit questions or technical issues via the private Q&A box. And we may respond privately to individual questions, but due to high attendance or potential volume, we may not be able to address or respond to all of the questions during the session. So for follow-up, if you choose, you can include your email address with your question, and we will be answering some of the questions that we receive at the end of our open session presentation today. So with that, I am pleased to turn things over to the All of Us Research Program CEO, Dr. Josh Denny. And Josh, the floor is yours.
Thank you, Rachel, and thanks everyone for joining us today. It's a pleasure to get the opportunity to talk with you about where we are with the All of Us Research Program. Next slide, please. So first off, I'm going to remind you of our mission. Our mission is to accelerate health research and medical breakthroughs, enabling individualized prevention, treatment, and care for all of us. And we have these three interconnected areas about nurturing partnerships with participants longitudinally for decades who reflect the differences in lived experience across the United States. We want to take this data set that participants contribute and make it as broadly available safely to researchers around the world. And we really catalyze the ecosystem of communities, researchers, funders that will lead to all of us becoming an indispensable part of health research. And I believe this year we've made considerable progress across, especially this last feature, and really all three as we are maturing as a program. We really are seeking to innovate in how we break down barriers, how we get research done, how we communicate back to participants to accelerate the real world impact of the program and the real world impact of precision medicine writ large. And one of our goals was to capture participants across the United States. And you can see we have all 50 states represented. We represent over 98% of ZIP3 zip codes. That's the level of de-identification that we report participants into in the researcher workbench. You can see that map there. We have most US territories represented as well. Over 870,000 participants have consented to join us. Over 600,000 contributed biosamples. Most of those are contributing blood and urine. And then some areas people opt for things like saliva. We are continuing to grow our collection of electronic health records. Over 90% of people say yes to contributing their electronic health records. Collecting them is an ongoing challenge and one that we continue to explore through many different means. And we continue to narrow that gap between those who want to share their electronic health records and those for whom we have electronic health records. As we talk about our participants, it's always powerful to put real faces on those. And these are many of our participants, are a small sampling, I should say, of our participants, but these are participants who have advised us in the program in various different ways. And this represents a small selection of participant advisors we have on community advisory boards as participant advocates for us that work directly in governance of the program, helping guide us, help us think through what's important, how we communicate, and helping review proposals that come through for new kinds of studies on the program and help us guide strategically in what's most important. You can see the quote on the side. Many of these come with stories of diseases in their families, in their persons as well. And we are delighted to collect those and really make our country a holistic whole towards making precision medicine real and better for everyone. As we think about our current focus around public health and chronic diseases as one of the really urgent needs to address in a greater way, we think All of Us really helps tackle the greatest causes of morbidity and mortality. Here, seeing the top 10 causes of death as of 2023 data, last year in which we have data from the CDC on this front. And with our ongoing longitudinal data that delivers both real world data and participant derived data, the ability to accessibly, easily access our data set to track health and disease through follow-up surveys, getting multimodal data on omic measures and connection to other data sources. We really believe we help tackle this in a cost-efficient manner to make a difference. Next slide. And if you look at just some counts on some of these, we accept all age ranges, most of which are adult at this point. But so some of those counts are accruing and in the early stages of accruing. But many of these, we have quite a significant number. Research has shown that we have a sicker population than the average US citizen and sicker than some other cohorts, but we still represent, as you saw, the entire country. And have really focused on geographic diversity as well as in other kinds of environmental diversity and race and ethnic diversity to get those lived cultural experiences, to get the genetic diversity to feed the kinds of discoveries we want to accelerate that will have relevance to the US population. And making our science available, affordable, democratizing access, and doing this in such a way that researchers can come in and produce easily reproducible science has been a focus from day one. We have created web-based, cloud-based models where researchers do their studies within our researcher workbench. They have two tiers of access, and registered tier and controlled tier. The genomics data and some other identifying kinds of data are in the controlled tier. And when people come in and build the analyses, they do it within our platform, which makes it easy to share for others to look at their work, to reproduce their work, to build off their work in ways with actually it even can send direct URLs that allow them to see the projects in papers and things like that. We also have a number of tools that are available in public to let you see whether or not a study is possible. Are there enough cases for the disease of interest or the exposure or the drug of interest to do that kind of study? The access is facilitated first by confirming institutional access, and we have over 1,200 institutions that have master agreements with us. Any new user coming on from one of those 1,200 plus institutions is able to complete steps 2 through 6 in really an hour or two if they go through all the steps consecutively. And then they're able to write real code or create real cohorts using point and click tools to build science on the process. The average across all our users is about 29 hours from first login to actually doing work on the program. There's no separate IRB approval, and users receive a free credits to start to help them get started with their analyses. It's led to a number of discoveries, and we're seeing a big upclick in those discoveries and publications coming out. About half of our current publication count, we're over 1,100 publications now, came in 2025. We are using LLMs now to help process those and identify papers that are related to all of us and classify them. They're actually using the data. These are publications made by researchers that are by and large not affiliated with all of us, but are coming in and using our data. They come from all 50 states and quite a few institutions. And so you can see some of the examples there, covering a range of genetic studies, non-genetic studies, environmental studies, many chronic diseases, some rare diseases as well in that process. And one of the things we thought was important is sharing those findings with our participants and the public as well. So this just gives an example, and you can follow the research highlight link here of some of the participant-facing summaries we've made of some of these kinds of work to make it accessible to our participants. And we send these out regularly as in newsletters and other ways that participants can find valuable to understand what kind of work is being done on the program. I mentioned that we have researchers from all 50 states, and right now it's approaching 21,000 researchers. We actually have had researchers use it from all 7 continents, and researchers who come in and are approved go through a vetting process that was described a little bit earlier with their institution and validation of their identity, and then using the system within our cloud-based platform instead of downloading data. You can see the representation there, and we across the country. And one of the things we're really excited about are the number of early trainees we have using the program. You can see, about 16% of undergraduates, researchers or undergraduates, 34% are some kind of trainee, 12% fellow. So we really do have a number of early trainees, and this provides an incredible resource that an early trainee and undergraduate student can learn about data science in the context of a class or a research project with one of the world's largest and richest data sets, learning to do work and learning these fields on health research that can actually help Americans and make discoveries. We've released a number of new tools this year, and this just highlights a few of them. One of these is the All by All browser, and this is a public resource you can go to now through our researchallofus.org website. It contains data on more than 500 billion genotype by phenotype associations, looking across a number of different types of data. So billing codes aggregated into phenotypes, lab values, and survey data that is all tested against the more than 1 billion variants that were observed in actually the last data set. So this is current as of the last data set before this one. And we are working on releasing a revised version that is on this current data set. These data sets are queryable to anyone in the public browser and also accessible computationally in the researcher workbench, so people can just query these huge tables without having to repeat these analyses. And there's a number of aggregations for like loss of function variants and other things like that. We also you can also survey genome variants through our genome variant browsers and look by different genetic ancestries, the frequency of different variants and their classifications and clinical interpretations if there is one. And working with NHGRI, we launched a new imputation service trained on our data. And you can see there's links there, and you can follow about our imputation service, which is worked with the NHGRI resources as well as all of those resources to really help impute arrays to deep genetic diversity and provide more accurate imputation service than what's out there so far. I wanted to give you a bit of a roadmap of where we are now in terms of data releases and what's coming in 2026. So the dark blue bar represents the current data available, about 630,000 people with survey data, about 414,000 with whole genome sequences. We think in springtime this year, we will be releasing our next data release, which is the light blue bars, which will have over 750,000 with survey data, over 535,000 with whole genome sequences data, and we'll increase the size of some of the other data sets. Exploring the Mind is one of our partnered research studies with, at the time, NIMH, and now is expanding to other partners as well. What you see there is we'll get a number of new individuals coming in with this data around quantitative measures of cognitive and behavioral aspects. The wearable data will increase as we bring in some Apple Health Kit data in addition to Fitbit data. We are increasing the long read and other multi-omic data significantly. So we'll have about 15,000 long reads. Most of those will have methylation data. We will be releasing a proteomic and transcriptomic data set and bringing in some metabolomic data as well over 2026. And finally, we're doing our first pilot with clinical narrative data that we've extracted from a handful of sites, and we'll be releasing conceptual extracts from those data with contextual information and things like that users will be able to look at. We hope to expand that over time. We know that it's important to take the data that participants provide or we're able to collect, and there's lots of other data resources out there. And one of the things we've heard from many of you in the community is data that we could link to. And so in the green are some of the data resources that we are looking at linking to. And I'm happy to say we have at least pilots or more in all of these spaces that we're looking at how we can bring these data in. With all of the data resources that we look to link to or that we collect, we go through a process of how we do it, privacy assessment, how we actually make those agreements and the kind of data that we share and the security around it. And then we also do demonstration projects to show the value of that data and test its validity. And so we have some demonstration projects also in play for some of those. On the right, we have really activities going in each of those areas right now. I've really talked about them in the last data slide as well, and we're looking forward to continue to expand those. One of the most common questions we get is on privacy and security. And it really, from day one, has been job one for us. We know that our ability to take these data and share them responsibly in a secure and privacy preserving way with researchers is critical to the trust of our participants. And that is sacred for us. I'm not going to read all the details in the slide. It's there and certainly will be available to review. But in short, all the data are encrypted in transit and at rest. We remove direct identifiers, including geospatial ones, as we share data into the workbench, and we computationally evaluate the kinds of data that we put into the workbench to think about the risk of re-identification. We are careful about how we do share identifiers in linking data, and as we work with groups to link data, we never are sharing the personal health information or the health information really, or any of that kind of data that we're collecting in detail with these other entities. In most cases, we're doing privacy preserving data linkages, so no one really even knows who someone is in the process. And even if in those cases, we're not actually sharing the all of us data there, we're getting data that's already been collected from those data linkage partners instead. We have a certificate of confidentiality, which helps protect for use cases other than research, and is part of federal law to protect us from having to respond to those other kinds of uses. We have a registration process. I've talked about some before, and they have to do their work in our cloud platform, which we monitor. And we have both. We have abilities to audit, and we drive audits by certain things that we would observe in the process of how people are using the workspaces. And those audits allow us to guide people to really follow best practices is typically what we find, and make their descriptions and their research plans a little bit more specific. The participant platform was changed in 2025, and we have moved to a new provider for our participant platform. So this has been a very active year for us in developing this platform, and we continue and will continue in 2026 to add a number of features to this platform and enhance its ability to support our participants, to return data, to support new kinds of studies, and ask questions with our participants. One of our priorities is getting people re-engaged on the new platform, and you'll see a lot of new offerings that I'll talk a little bit about in terms of things people can do on the platform. If you are a participant, I'll just encourage you, if you haven't logged in over the last year, you'll have to reset your password, and I encourage you to come on, see if there's anything new, set your preferences, reset that password as you come in for that first time on the new platform, and make sure your contact information is up to date. One of the important parts of the program has been returning individual results to researchers, to participants. And this gives a couple examples. We have many more things, from exploring the mind, mental health, well-being on the left. One of the biggest from the beginning was returning genetic results. And we heard from participants as we did kind of like focus groups, community engagement studios across the country, that DNA results were some of the things that people were most interested in. And so we have now completed return of results to over 270,000 individuals. And you can see there the two major kinds of health-related reports we're highlighting here: hereditary disease risk of things like cancers and cardiomyopathies, arrhythmias, and other conditions. We've returned results that have real implications to one's health. In some cases, these are risks of sudden death or cancers. And that's about 3% of the population. It is stable, we see, across different genetic ancestries. It's about 5,500 total people that have received these results. And we know that most people don't know about these kinds of results before we get them. In addition, we've returned pharmacogenetic information through a medicine in your DNA report, and that's been 145,000 people. About 86% of people that have chosen to get this report have found an actionable result that would affect one or more medications. About half of people have more than one actionable result in a pharmacogene. And so, and this looks at 50 common medications and that could have real health impact. The Now, talking again about what's going to happen in 2026, one of the things I'm most excited about in 2026 is a reassessment survey that we will be, for the first time, getting updated measures around some of our key surveys and physical measures. We would like to be doing biospecimens. The current funding situation doesn't allow us to get repeat biospecimens, but we are building out capabilities to do that as we could in the future. And so looking at those surveys that are coming, we're calling it the All of Us Check-in. Participants will soon be getting emails about this, and it will include update on these 5 different modules: the physical measures, health and wellness, social factors, mental health and well-being update, and then the personal and family medical history forms will all be opportunities to update. And with this, they will return. Some of these modules have specific summaries of changes in some of the data over time, such as a physical measurements piece. And if they do this, we'll also get a $10 digital gift card when they complete these various surveys. We also continue to build out our protocols around pediatrics. Our pediatric is mostly in a pilot phase, but you can see we've expanded a few different sites across the country. We have had most of our enrollment in really the latter part of 2025. It's now over 1,600,000 children, all associated with parents or guardians who are also enrolled in the program. And most of that enrollment actually happened in the second half of 2025. We currently are working on expanding from 0 to 4 to 0 to 12 and figuring out processes to allow collection of biospecimens reliably across the United States for kids. That will also be factored in for how we would do that for adults. And then we are also, as we think about that, we will be able to enable digital participation for kids as well. We know, I believe, that there are over 100,000 kids that are associated with parents or guardians already in the program, for instance, and we would like to invite them to enroll their children once we have the capability of doing so. One of the things, papers and announcements this year that has very real translation to participant health and patient health across the US is a new polygenic risk score clinical test that was developed based on All of Us. This was developed by Broad Clinical Labs and Mass General Brigham, looking at 8 cardiovascular conditions that were trained across our diverse genetic ancestry population and then tested within their biobank. These polygenic risk scores look at many aggregated effects of up to millions of genetic changes that we could each possess, that each have small effects on risk of different conditions, but in aggregate can have a large effect that can be equivalent or exceed some of the Mendelian causes and sometimes. And so what you see here on the right is what the report looks like for this clinical test that's now offered to be ordered really by any provider in the US. And one of the ways that we continue to build on All of Us, we think of All of Us as a platform, our partnered research studies. So I invite you to follow the link and learn more about these. These are 4 of more than 4 that are currently ongoing partnered research studies using All of Us. And these are some of the larger ones doing different things. Nutrition for Precision Health is really a key program looking at nutrition in depth, includes randomized diets and detailed questionnaires of before, after with exposure of the diets, and in several different phases. The largest phase of this involves 8,000 people, all of it embedded within All of Us. Eyes on Health launched this summer and is collecting digital imaging, ocular imaging, both retinal images and OCT images that, of course, will be integrated with all the rest of the kind of data that we have. We have a study that will be completed the data generation phase. and in data curation and other steps to get that data out there on the environmental influences of type 2 diabetes. And exploring the mind is one that started, I referenced earlier, looking at cognitive function and behavior with quantitative measures through games that people play with different imaging and other aspects. And it's been completed by over 84,000 participants. Excitingly, that started with NIMH, and a number of other institutes and centers have joined on. And so we will be re-releasing that with an expanded set of offerings with support across a broader set of institutes and centers at the NIH. And excited to announce another NOFO that's coming for an X01 that's anticipated in April of 2026 that will allow individual investigators to apply in a competitive fashion to be able to access all of us biospecimens. The grants.gov notice of expected NOFO is there, and I encourage you to read the information there. Obviously, given the state of this now, more is one of the things where much more information will be coming as this becomes public and announced. But just to highlight on the right, we have over 14 million aliquots for more than 4 million primary biospecimens around blood samples, urine samples, saliva samples, the vast majority having blood. We've really focused on use of DNA. And so there's just a really rich wealth of data there. And we look forward to broadening the access from the pilots we've done internally with institutes and centers to allow investigators to propose their ideas. You will need to come with the funding as an X01 mechanism but competitive ideas looking across broad factors and broad data generation that will be included back in the resource. We really look forward to getting many applications in this front. Next slide. So please stay in touch and please watch for announcements in that area. Our focus in 2026 starts with reactivating, reassessing, and re-engaging our cohort. It's been last year, with the transition in our participant platform, we didn't have any new surveys to offer. This year, there's a number of new modules we'll be offering, and we're going to bring people back into the new participant platform. We're also building out our plans for return of value going forward and looking at new kinds of genetic offerings we could hopefully return as well. We want to continue to build on our data set. Importantly, I already mentioned the next data set with over 750,000 surveys, over 535,000 whole genomes as the largest and most diverse genetic ancestry data set of its type in the world. And we are building new data releases and after that, and how we think about innovative data types we can bring into it. I'd like to continue to expand our narrative data offering, for instance, and explore other kinds of data that we can include, both of linkages or maybe other direct assessments. And we want to continue to really grow partnered research studies. Partnered research studies really are our avenue for growth in the future. The X01 that's coming is a key part of that, but we also will be offering a number of other partner research studies that will be starting and continue to grow that pipeline internal to the NIH. So this gets a little bit more granular in detail and timelines in Q1 very soon. Your Whole Health is a partnered research study that gets a holistic opinion through 9 questions of your health and gives some graphical depictions of that afterwards. Right now, there is a beta that has launched for the Research Workbench 2.0. We're undergoing a major change there. That platform is available for researchers in the Workbench. Any researcher in the Workbench can start exploring the Workbench 2.0. It is a beta now and is continuing to evolve, but you can start doing the same analyses you did on the other Workbench in there. And so I invite people to use it, give us feedback. In spring, we'll have the participant reassessment started. In Q2, at some point, we will expand pediatric enrollment to 7 to 12 at our enrolling sites. We will have that next major data release that I talked about. And I hope everyone marks their calendar for April 15th, not just for tax day, but our science day as well. So get your taxes done early. In Q3, we'll plan to open pediatric virtual enrollment to our existing participants. We'll have another partner research study. In Q4, we'll have another partner research study. And then 2027, through the course of this year, we need to build out our next strategic plan. Our strategic plan was set to end at the end of 2026. So that will be our next strategic plan, is a goal for this year. So finally, just thank you. Thank you for paying attention and listening and your interest in all of us. I'm happy to address a few questions.
Thank you so much, Josh. All right, let's go to some of the questions that we've received. Is All of Us still enrolling?
We are still enrolling. The pace of enrollment has curtailed significantly since the funding decreased over the last 2 fiscal years. We had a greater than 75% budget cut. And so that has the biggest impact of that has been on enrollment, because people can come in and share data. Sharing biospecimens, generating genomes is where the cost really comes in. And so our digital front door will remain open. People can join. And through partnered research studies and other efforts, we are still collecting biospecimens on just smaller numbers, a smaller rate of participants than we used to have, but we're still open.
Thank you. I wanted to actually myself address one of the questions we've been getting quite a bit, which is, are the slides available? So we are recording this session. We do typically put it on our All of Us YouTube channel. So this content will be available. Another question we got is, can you expand a bit on the difference or plans for publication? So the All of Us overall publications versus the publications from researchers using All of Us data.
Yeah, great question. So most of the now it's actually over 1,200 publications have come out, have been through external researchers doing work through the Research Workbench on the program, and we really are a platform to enable that. And that's the 95% plus probably of all publications will be that kind of publication. It will grow over time. It'll probably be virtually 100% over time. We as program put out marker papers, descriptions of methods, initial demonstration projects, catalogs of the kind of data we have or how we clean it, and things like that. And so we continue to do those. We are working on a manuscript now that will go into detail on our return of results, genetic return of results. And that is in a finalization stage. And that's the next kind of what we call a marker paper from the program that really goes into those important efforts, how we work, worked with the FDA and all the processes we went to do that.
Great. Also, can you clarify a bit? Is there a cost to use the Researcher Workbench for analysis?
There's no cost to access the data. When you come in, you actually get a $300 credit to start your analyses. That's great to do a lot of analyses with survey data and EHR data. When you start doing genomic analysis, that helps you get started. But when you do deeper analyses using the vast petabytes of data that we have, that will incur costs. You just have to pay for the ongoing cost of your compute time and storage cost. And there are different ways you can pay for that when you get in there.
You mentioned omics data that will be released soon. Will it have matched whole genome sequence data?
All of the omics data, the multi-omics data that we're generating, are produced on participants that have whole genome sequence data. And almost all of it, it may be all of it, also has EHR data. And they are all participants that have core surveys as well.
So then from a participant perspective, let's say I donated my blood samples in 2017. There are still studies being done on those biospecimens. That's a question we got as well.
Yes, as people have contributed biospecimens, there are still studies being done on those. And the first thing we did from a central standpoint is whole genome sequencing. And then that's part of one of the ongoing partnered research studies and other efforts, is to generate more data from those biospecimens.
Another question we received is, has cancer registry data been linked to All of Us?
We have not linked cancer registry data yet, but we actually have an ongoing project now to link to SEER data on our current participants.
And I know you spent some time talking about this spring's next big data release to the Researcher Workbench. What's unique about it?
The biggest thing is much bigger numbers. So we'll go from 410,000 or so with whole genome data to over 535,000 with whole genome sequence data, and a significant larger set of people with EHR data as well. So, and more surveys, all the numbers grow, essentially. The biggest growth will actually probably be in that all the multi-omic data that's coming out. The long read sequence goes from 2.7 thousand to 15,000. You'll have for the first time methylation data to look at environmental exposures from that fashion. You'll have proteomic data and other like transcriptomic data and metabolomic data that we'll be covering as well. So all those kinds of data sets are actually, those are all completely novel for us, in addition to just the overall larger data set and more longitudinality. You add another year plus of phenotype data captured through electronic health records and other sources.
Thank you. Another question we received, and then I'll start to wrap it up, is could you clarify the current status of pediatric enrollment in All of Us, how it hopes to expand in 2026? I saw Q2 on the slide, but was hoping to clarify.
Pediatrics was the next space that we were moving into, and our priority for enrollment to really capture across the age span, lifespan. And the vast majority of our people are 18 and over. And I mentioned that we are about 1,600 kids so far. I will mention that we have about 40,000 individuals that enrolled after 18 that have retrospective pediatric data in their electronic health records that they've shared, and a lot of people are using that data as well to investigate some pediatric outcomes. But we really want to grow, and we think the number, it needs to be tens of thousands, and really, ideally, would grow to over 100,000 individuals, kids that we could follow longitudinally, integrated, and so we're pursuing a number of different avenues with that. I would describe what we're doing now. It's a smaller growing process to help us build all the framework we need to enroll kids and to work out the protocols at given sites and then open up nationally. And it will continue to be a slower growth rate than we're used to seeing if you follow the program for years, when we had a really robust set of healthcare provider organizations and national efforts. But we remain committed to pediatrics and growing that through a number of different avenues.
Wonderful. Well, that does bring us to the conclusion of our open session. So I want to say thank you, Dr. Denny, and thank you to everyone who joined and asked questions. And again, we will be putting the recording of this on our All of Us YouTube channel. So have a wonderful day, and thank you so much.
Thank you.